session where we are going to take NEET PG revision topics. So these topics I've taken, mainly from the question analysis of last 4 to 5 years. That which are the questions which have been very frequently asked, right? So those questions I've really taken that. Yeah, those questions I have taken, or those topics I have taken where the questions have been asked repeatedly, right? So that we can really have a look over, like we say when we study, which topics are those which are frequently asked for NEET PG. So that topics I'll be discussing today. So I hope people are connected and you can if just give me a hi, hello, so that I can understand. Yes, ma'am. Am I audible, visible? Good evening, good evening. Yes, so let's get connected. So before, just give me a second to let me tell you that we have come up with the next batches, and you can see the offer being provided. You can use the code REAP9 to avail more benefits. We have also come up with the NEET PG Vitals, which is the first recorded session being available. It is going to be very effective, which is made up by all the wonderful mentors for you. So please go through it. And a scholarship test which is free to be enrolled. So just look into the dates. It's 18th June and 100 questions are there. Yes. So good evening everybody, medical buddy, Mohammed, Sandhya, and all those who are connected. So let's get ASAP connected with those topics which are very favorably and repeatedly being asked in the NEET PG. I've analyzed the last 3 to 4 years questions and I've come to these topics. Now the first picture which I'm showing you, it is electron microscopic structure of the skeletal muscle. Okay, electron microscopic structure of the skeletal muscle, and you can see that it shows gross striations. तो जब भी cross striations आते, you are asked like what is this band. So you can see that this band is comparatively a lighter band, right? So because this is a lighter band, right, because this is a lighter band, it is definitely going to be my I band. That means most laterally which I am starting is from the light band, because a sarcomere, अगर आप देखते हैं, what is a sarcomere? It is the bands, or it is the place or these sites which are between two sarcomeres, है ना? Sorry, between two Z lines. So the portion between two Z lines is the sarcomere. This sarcomere is actually made up of, if you look into this sarcomere, there is half I band, a full A band, and a half I band on either side. इसीलिए most laterally is going to be this light band, which is the A band. Light band के अंदर अगर जब आपको ये dark line दिख रही है, when you are seeing a dark line within this I band, which is passing through this, is the Z line or the Z disc, which we are differentiating from the other bands. Then come on to this center, which is the A band, which is the dark band. Okay, the center, which is the dark band, and dark band के बीच में what do you get is the H zone, and in the center of the H zone we get the M line, right? In the center of the H zone we get the M line. What is this M line? What is this M line? This M line is nothing but it is a place of reverse polarity of the M line, is the site of reverse polarity of the molecules, myosin molecules. Now one important thing which you should remember, that this is the striated structure which you are getting in the skeletal muscle and the cardiac muscle. Okay, the striated structure in the skeletal muscle and the cardiac muscle. But what is the difference in the smooth muscles? So in the smooth muscles you have got like this, they are spindle shaped structures, and this Z line is replaced by the dense body. So this is an important MCQ, that in the smooth muscles, if there is no Z line. What is present? So dense bodies are there which replace the Z lines, because this is the site for attachment of the actin. So you can see that actin is going to be attached from all the sides, and here in the center you have got the myosin, right? Another important thing when we cover the smooth muscles, which is very very interesting. In the smooth muscles, see, the skeletal muscles also have got actin and myosin, right? But in the smooth muscles, the proportion of actin is about 12 times more than the proportion of myosin. This is very interesting, that the myosin is much lesser. Like in the striated muscles, that is in the cardiac and in the skeletal muscles, this ratio is 2:1. Okay, this ratio is 2:1. But in the skeletal muscles or in the cardiac muscles, this ratio is 2:1. But in the smooth muscles, this ratio is 12:1. That means at any given time, myosin proportion being more than actin, it can form cross bridges at any direction, because there is no horizontal alignment. Okay, there is no horizontal alignment, they are distributed at any angles. So myosin will always have actin to bind to it. So the same thing which we are going to cover in next 2 to 3 slides ahead, when I will be covering the Laplace law, I will again concentrate on this portion, right? And you must remember that H zone, okay, H zone is the zone which is going to be absent with muscle contraction, right? H zone is going to be absent. So which zone is absent with muscle contraction? It is the H zone. What is the reason? H zone is that portion within the A band, okay? It is that portion within the A band where the actin and myosin are not overlapping at rest. They are not overlapping at rest. So when the muscle contracts, the actin and myosin will overlap, and as they overlap, the Z zone will disappear. So this becomes very important as far as the H zone is concerned. Okay, and remember that this sarcomere, it shows a length tension relationship. This peculiar length tension relationship is the molecular mechanism of the length tension relationship, which is also valid to the Frank-Starling's law. That is, only at a particular length of the sarcomere there will be optimum overlapping of actin and myosin. So I repeat, only at an optimum length of sarcomere there will be a maximum overlapping of the actin and the myosin, and that optimum length is around 2 to 2.2 micrometers, whereas this specific length tension relationship is not present in the cardiac, in the smooth muscles. The smooth muscles, they show plasticity, which we will see later on. Now the next important topic where you get important questions are the questions on the sarcotubular system. You get something very important questions in the sarcotubular system. And if you remember, there was a question on excitation contraction coupling. याद है, पढ़ा था आपने? Excitation contraction coupling में the question was asked regarding the source of calcium in the skeletal and the cardiac muscles. Now which one is correct? Let me know. Okay, which one is correct? So in the skeletal muscle, which is the source of calcium for contraction? So let us rule out this first, and then we will understand the differences in the sarcotubular system in the 3 muscles. So in the skeletal muscles, the source of calcium is 100% ICF. What is ICF? The sarcotubular system, or the, you can say, the L tubules, which are the storehouse of calcium, right? The L tubules, which are the storehouse of calcium. The entire calcium which is required for muscle contraction is coming from these L tubules. If you compare this to your cardiac muscles में क्या होता है? That 1/3 of the calcium is coming from the ECF and 2/3 of the calcium is coming from the ICF. So once this calcium comes from the ECF, when does it come? It comes during the plateau phase, this phase. It comes during the plateau phase of action potential of cardiac muscle. This is a kind of a calcium induced calcium contraction, okay, a kind of a calcium induced muscle contraction in the cardiac muscles. I'll just take on this. Before that, let me complete that in the smooth muscles, when you compare the source of calcium, the 2/3 of the calcium are coming from the ECF and only 1/3 of the calcium is from the stores. What is the reason? The smooth muscles, they do not have an extensive sarcotubular system. What they show is, see, this is the smooth muscle or ऐसे rudimentary T tubules which are called as alveoli. Rudimentary T tubules which are called as alveoli. Okay. So this is regarding the source of calcium in the three muscles. That totally depends upon the difference in the sarcotubular system. Now when we cover the sarcotubular system, we will be covering the sarcotubular system ka differences in the skeletal muscle and the cardiac muscle, and what is the calcium induced calcium release and the voltage sensors. So this sarcotubular system, it is composed of two important tubules. See, one is this T tubules. What is this T tubules? These T tubules are nothing but they are simply the invaginations of sarcolemma, right? And what is the function of this T tubules? Be very specific. The function of the T tubules is that they have to spread the action potential to the interior of the muscle. So once they are spreading the action potential to the interior of the muscle, there will be a massive depolarization. Why do you need that depolarization? We need that depolarization because we have to open the voltage gated T tubule channels, that is the DHP receptors. Okay, so why do you need that action potential? We need that action potential because we want those T tubules to open up, which are voltage sensors. On either side of the T tubules, you can see that there are L tubules. These cisterns, longitudinal cisterns, which are the source of calcium. And these longitudinal cisterns have got the rhinodine receptors. Okay, they have got the rhinodine receptors. Now there are two important things which have to be considered. So first we will see that this rhinodine receptor, which is actually going to release calcium, is subjected to a mutation. So when there is mutation of this calcium channel, there occurs a mutation, channelopathy of the excitable tissue, which is malignant hyperthermia. Okay, this is nothing which is malignant hyperthermia. This question is very, very commonly asked. So malignant hyperthermia is the mutation of this rhinodine calcium channels. Remember that they are not voltage gated. Very, very important that they are not voltage gated. Malignant hyperthermia mein you will see that you may be given a question that a person was subjected to surgery. He's been given some anesthetic, and after that anesthetic the temperature of the muscle rises. So that is because of the outpouring of calcium that is coming from this rhinodine channels. That calcium causes an increase in the muscle contraction, that causes a muscle rigor, and increase in temperature is going to be a very, very important feature of this condition. So the sarcotubular system में first important thing जो हमको पता होना चाहिए, that is malignant hyperthermia. Now the second important thing which we need to know is what is the difference in the sarcotubular system of the skeletal muscle and the cardiac muscle. Now look here, I'm going to draw two sarcotubular systems and you have to tell me which one is of the skeletal muscle and which one is of the cardiac muscle. This is one sarcomere and this is the sarcotubular system, and this is another one. Yes, if I label it A and B, can you tell me which one, A or B, is that of the cardiac muscle, and then why? I will teach you. Which of them is of the cardiac muscles? Yes, come on. Give answer so that let me know that you are physically and mentally associated with me. Which sarcotubular system is of the cardiac muscle, A or B? Yes, and then I'll let you know that what is the reason behind it. Anybody? The question is not so difficult, beta. Come up. Okay. So the cardiac muscle is this, B. Very good, Tamalika. Good, beta. Very, very good. Yes, good. So now let us consider that why it is of the cardiac muscle. In the case of the skeletal muscles, I told you that we are not depending upon the ECF for calcium. We only want the action potential to spread. So this is long and narrow. These T tubules are long and narrow, and the triad, that is, this is the triad where there is L tubule, T tubule and L tubule. So this triad is going to coincide with the AI junction. In the skeletal muscles, it is going to coincide with the AI junctions. Okay. In the cardiac muscle, we are depending upon the outside calcium. So this T tubule is going to be wide and short in comparison to skeletal muscles, and the triad is going to coincide with the Z line. Okay, it is going to coincide with the Z line. This is structural difference. Second important thing which we need to understand in the skeletal muscle and the cardiac muscle. Now we know that there are DHP receptors. Okay, there are DHP receptors in the T tubules, and there are rhinodine receptors in the L tubules. In the case of the skeletal muscles, these DHP receptors are only voltage sensors. They are not releasing calcium. They are only voltage sensors. They are not releasing calcium. So as soon as the action potential will come, there will be opening of the DHP receptors. These DHP receptors just bring about a mechanical conformational change, and they open the rhinodine receptors, which will then pour out the calcium. So it is just like a lock and key phenomenon, as if there is the lock in the rhinodine and the DHP का जो T receptor है, it is a key, और वो उसको खोलेगा and the calcium will be poured out. So they are just voltage sensors, and this type is called as a voltage induced calcium release. Okay, a voltage induced calcium release. In the case of the cardiac muscle, so this is with the skeletal muscles, what happens in the cardiac muscles? I told you that the cardiac muscle is depending upon the ECF वाला calcium. सबसे इम्पॉर्टेंट बात, जितना ज़्यादा ECF से कैल्शियम विल आउटपोर, ठीक है, आई रिपीट, जितना ज़्यादा ECF से कैल्शियम विल आउटपोर, more and more of calcium will be released from the ICF, that is from the stored tubules. So when you are giving the drugs which are going to act on the calcium channels, they could be either calcium channel inhibitors, they could be either calcium channel stimulators. जो भी ड्रग्स होती हैं जो इंटरफियर कर रही हैं इन कमिंग ऑफ द कैल्शियम इन द plateau phase of the cardiac muscle are going to hinder the muscle contraction. So if they allow more calcium to come inside, there will be more forceful contraction and so on. Now यहाँ पर the DHP receptors, they open up with change in the voltage, ठीक है, they open up with change in the voltage, but these will also pour calcium. As they pour calcium, this calcium will cause release of further calcium. It will cause release of further calcium from the rhinodine receptors. So this is called as a calcium induced calcium release. So when you get a term calcium induced calcium release, it is with the cardiac muscles, where the outside calcium is needed for opening of the calcium which is present inside. Am I very clear? Are you understanding? Are you understanding, everybody? You can put a yes or you can put a no so that I can repeat if you want. Is it everything is very, very clear so that we can move on further now? Now after this, the next very important topic and a very repeated questions which comes is on transport mechanisms. Okay, transport mechanisms. Many a times you have seen that images were given to you. Very good. Thank you, Tamalika. I don't know what are others doing. Thank you very much for responding. Now, if you get image-based questions, it should be very, very clear that what type of transport mechanisms we are given the question upon. So, if you see couple of years back, you were given a question on a figure which was actually related to facilitated diffusion. Now, how I come to know that it is facilitated diffusion? One thing which is very clear in facilitated diffusion is the conformational change in the carrier molecule. A conformational change in the carrier molecule. So you yourself can appreciate this, that as this transported molecule binds to its binding site, okay, as the molecule to be transported excuse me, binds with the carrier protein, there occurs a change or a conformational change, and that results in the release of that carrier molecule. Nowhere you can see that ATP is used, so there is no use of ATP. Okay, so just a conformational change and there is no use of ATP. Don't confuse this with with secondary coactive transport, because secondary coactive transports, whether it is coactive, whether it is counter transport, whether it is co-transport, will always have two molecules. See over here, two molecules will be there, sodium amino acid, sodium glucose, or so on. So it will always have two molecules which are either transported on the same side. So when it is either transported to the same side, or one moving out, one going out, it could be a symport or it could be an antiport, right? So you can see that at any time you are never going to get, you're never going to get a change in the conformation. Conformational change will not occur over here, and ATP may shown, may not be shown, because the secondary coactive transport or counter transports do not directly use ATP, right? They do not directly use ATP. That is the major difference, right? Then the next important is there was also once a figure that was related to the sodium potassium pump, where you were asked the binding sites. Okay, so you can see that it is a heterogeneous heterodimer. It is a heterogeneous heterodimer which is having two subunits, alpha and beta, where the alpha is actually the active site. Why do we say active? Because all the binding sites are present on the alpha. So the binding sites are present on the alpha, and the beta only shows or has glycosylation sites. Okay, it only has got glycosylation sites. This comes as an image based question, wherein you may be asked that which is the sodium binding site or potassium or so on. Now remember, it has got a coupling ratio. It has got a coupling ratio of 3:2. That means 3 sodium is poured out and 2 potassium is taken in. Obviously, if you have to throw out the sodium binding site will be inside. So this is an image based question where you must know that intracellularly, this is inside, Intracellularly, you will have the sodium binding site because you have to throw the sodium outside, whereas you have to get the potassium inside, है ना. So इसीलिए the potassium binding site will be outside on the ECF. As we know that this is inhibited by digitalis, which will also going to bind the extracellular site. So QBank or digitalis, that is the cardiac glycose site, will always have a binding site which is outside. 4 and 5, they are supposed to be the sites for binding of ATP and phosphorylation. Okay, binding of ATP and phosphorylation. Now another important 1 or 2 MCQs related to this sodium potassium pump, which you must know. You must know that this sodium potassium pump, and just now I revealed that it has got a coupling ratio of 3:2. This is inhibited by and stimulated by certain drugs. So it is stimulated very importantly by your thyroid hormones, and these thyroid hormones, they increase the BMR, and one of the mechanism of increasing the BMR is increasing the activity of mitochondria, number of mitochondria, plus the sodium potassium pump. It is also stimulated by insulin, and this is how insulin takes up the potassium inside and also contributes to the ECF potassium. So a patient with diabetic ketoacidosis, right, that patient, when given insulin, the potassium levels will decrease, they'll be taken inside. This is a question related to it. It is also stimulated by aldosterone. Don't get confused with ADH. ADH has got a role on water primarily, not on sodium. But aldosterone has got a role primarily on sodium, and as it reabsorbs sodium, water is reabsorbed secondarily, right? So you must remember that thyroid hormone, insulin, aldosterone, these are the ones which are going to stimulate your sodium potassium pump. It is inhibited by atrial natriuretic peptide, it is inhibited by dopamine, and we also saw that it is inhibited by the pharmacological cardiac glycoside, that is digitalis. So this comes as a very important question to you, which you must remember. Now, what is this? What is this? This is very interesting. See, you can see that there are two molecules, A and B. And this molecule A, if anytime I want to give an image based question, I am showing you that easily it can pass through the cell membrane, isn't it? So this is nothing, but this is what is just showing me that this is simple diffusion, isn't it? It is simple diffusion. So this can be remembered as an image based question, that it is simple diffusion where easily the substances are going through. But here we are needing some kind of channels, some kind of pores which have to be opened, and then only the substance can pass. So this is for our water soluble substances which could require transport carrier proteins, which would require facilitated diffusion. So if this comes as an image based question, look over to it, the solubility, look over that there are no channels for the lipid soluble substance. Next common topic which has been repeatedly asked is regarding the concentration of ions in the ECF and the ICF. Very repeatedly it is asked. Just go through the questions and you will see that many a times this question is being taken in different forms. So when we consider our ECF and ICF, okay, so this is my ICF. I can see that the major cation in my ICF is potassium. Apart from potassium, what important cation is there is magnesium. So potassium and magnesium are more in the ICF. If I consider the anions, it is the protein and it is the phosphates which are present more in the ICF. Comparing this to my ECF, the major cation is sodium and the major anion is chloride. So it is sodium and chloride in the ECF. Apart from this, bicarbonates are also more in the ECF, and calcium is also more in the ECF. This is very important, I would say. Out of this, one important thing regarding sodium, it is the most important ion to maintain or to contribute to the ECF osmolarity and to the ECF volume. So whenever you see that there is, you know, the water redistribution, and whenever there is change in the osmolarity, one of the most important ion to be considered is sodium. So your osmolarity is in the range of 280 to 290 milliosmoles per liter, and the maximum contributor to osmolarity is sodium. Remember, the maximum contributor, about 220 milliosmoles per liter osmolarity, is by the sodium. Wherever sodium will be there, chloride will be there. Okay. Hello Rishi. Namaste. Okay. सोडियम एंड क्लोराइड आर वेरी गुड फ्रेंड्स. सो जहाँ पे भी सोडियम रहेगा वहाँ क्लोराइड रहेगा. रिमेंबर, अंडरस्टैंड दिस, एंड दीज टू आर गोइंग टू ऑल्सो इंक्रीज द रीअब्जॉर्प्शन ऑफ वाटर, राइट. बाइकार्बोनेट इज अ वेरी important ECF buffer, right? Bicarbonate is a very important ECF buffer. When we consider our ICF, you have got proteins and phosphates. If you look into the concentration, obviously the concentration of the phosphates are more than the concentration of proteins, but an effective buffer is my proteins. Both of them are buffer, proteins as well as phosphates. But if you have to compare, if you have to give me one answer, I would tell you that the proteins are more effective buffer intracellularly, right? Moving on next. Yes. Now, another very important question which comes to us is on the action potential and the ionic basis of the action potential. This is the question which have been asked. Just go through your NEET PG questions last year also. You will see that even in INICT, when in NEET PG, these questions are being repeatedly asked. Now, with this point A, you know what is this point A? You must understand that also. So here the RMP, this point A is the RMP, that is resting membrane potential. Now the RMP of the different tissues is different. The reason is that it depends upon the ICF and the ECF distribution of ions, right? So RMP point A is the RMP. Now what is point B? You can see that this RMP shown over here was -80, and it has become slightly positive over here to -60. That means this is the point which is actually resulting in the threshold for excitation. Okay, a threshold for excitation, which is because of the positive feedback mechanism, that is opening of the sodium channels, which is also called as the Hodgkin's cycle. So Hodgkin's cycle in case of action potential is that opening of the few sodium channels is going to result in opening of more and more of the sodium channels. That sodium channels will come inside, it will neutralize the negativity and result in this upstroke. So up till point D, whatever positivity which we are creating is only because of the sodium influx. It is only because of the sodium influx. When you give a threshold stimuli, okay, suppose I gave a threshold stimuli over here, you open both the channels, sodium and potassium, but that voltage, okay, that voltage is going to prefer the sodium more than it prefers the potassium. Okay, it is going to prefer the sodium more than it prefers the potassium. इसलिए the sodium influx will be more, and that is going to contribute to our sodium to our depolarization, or that is the upstroke. At point D, there is closure of the sodium channels because they are voltage gated, and there is going to be opening of the potassium channels. And the potassium, as they open up, there is always going to be efflux. What is the reason? The reason is that the ions, they move along their concentration gradient. So the potassium is more in the ICF, so it will move out, and you are returning back towards RMP. You get this point F, which is also called as the after hyperpolarization. After hyperpolarization, where the RMP becomes more negative. Okay, RMP becomes more negative. What is the reason? The reason is the slowed and the continued efflux of potassium ions, because the potassium channels, they are slow to open, they are slow to close, and they result in the continued efflux, and therefore this RMP will always be re-established by the sodium potassium pump. So the important function of the pump is the re-establishment of this RMP once the action potential has been done. Okay, so you must remember that if you are asked point wise, so point A is what? It is the RMP. Point B is the threshold for excitation. Point C is the overshoot. Okay, the overshoot has crossed 0. It is going to be the overshoot till D. Then E is repolarization, and F is after hyperpolarization. Now out of these various points, that is A, B, C, D, E, F, which is going to be the point which is least excitable? Anybody can come up? Yes, Rishi? Anybody? The point which is least excitable, or the point where the tissue is very difficult to elicit the next action potential. What is that? Anybody would like to try? Yes, so that is going to be the point F. Point F. What is the reason? You can see that the RMP has become more negative. More negative RMP. So it is difficult to elicit the tissue now. If the RMP is suppose minus 70, you can take it up to minus 55, comparatively easier, है ना? But if the RMP is suppose minus 90, then from minus 90 to minus 55, isn't it more difficult? So the tissue is going to be more difficult to take back at the point of hyperpolarization, which is more negative than the RMP, and therefore you require the sodium potassium pump, so that the potassium which is gone outside will be again coming back inside, and the negativity will be then brought back towards the RMP. Next important thing which you must understand over here is the, you must understand that what is the absolute and the relative refractory period, and what is the cause of it. Okay, so the absolute refractory period is from the point you gave the stimulus, the response started to 1/3 of repolarization. Okay, up to 1/3 of repolarization, and the cause of this absolute refractory period is the inactivation of the sodium gates. Okay, inactivation of the sodium channels. Whereas after this 1/3 of repolarization to the completion of the action potential is the relative refractory period, and in the relative refractory period you need to give a supra threshold stimuli, because if you give a supra threshold stimuli, then what will happen? That the sodium channels are coming out of their inactivation gates or inactivation state, and they will open up. So that is a very different topic to be taught, because there are two types of gates the sodium channels is having, activation and inactivation. Moving on, next is to the action potential of the cardiac muscle, which is asked, and again you are asked the ionic basis of the action potential. So you can see that this is a plateau where the RMP is around minus 90. This is also called as the ventricular action potential. Okay, this is our ventricular action potential, and it is a fast response. Why we called it a fast response? Because the SA node has got a slow response. Now the phase 0 is depolarization, which is, you can see, because of the sodium conductance or conductance of the sodium ions. You get an initial repolarization because of this transient potassium channels, the transient potassium channels which open up and result in the efflux. But immediately there is a plateau. This plateau balances the calcium influx with the potassium efflux. These are long lasting calcium channels. Okay, they are long lasting calcium channels or slow type of calcium channels which are causing the influx of the calcium, and this calcium which is coming during the action potential is also opening the calcium channels inside to release more calcium for contraction. The phase 3 is repolarization, that is again because of the closure of the calcium channels and opening of the potassium, and stage 4 is the RMP, that is contributed by sodium potassium pump. So you can see that the different types of channels, have just taken a table. In the cardiac muscles. Okay, so fast sodium channels responsible for the phase 0, that is depolarization. Okay, then the funny sodium channels, that contribute to the pacemaker potential in the SA node. Calcium mein you've got long lasting calcium channels that are responsible for the plateau phase, and there are also transient calcium channels that are responsible to the pacemaker potential in the SA node. Then you've got lots of potassium channels right? As far as the potassium channels are concerned, inward rectifier, transient outward, delayed rectifier, ATP sensitive, acetylcholine activated, and calcium activated. Remember, when we consider the potassium channels, the two very important potassium channels, apart from those which are present in the cardiac muscles, you must remember two important potassium channels. One of them is ATP sensitive. ATP sensitive potassium channels, and the other is the hypoxia sensitive potassium channels. Okay, ATP sensitive and the hypoxia sensitive. So the hypoxia sensitive potassium channels are present in the glomus cells, that is in the carotid chemoreceptors, the carotid bodies. In the carotid bodies, ATP sensitive potassium channels are present in your pulmonary circulation. Okay, in the pulmonary circulation, ATP sensitive. They are also present in the beta cells of pancreas. So in either of the case, what you will do is you will bring about the closure of the potassium channels, and you will bring about depolarization. Okay, the closure of the potassium channels and depolarization. But their closure here is brought about by hypoxia, and over here is brought about by ATP. That is the difference. So you've got a very, very important question on the potassium channels. Moving on, next was the question which was related to the clearance graph. Okay, this was the last year INICT question, if you look upon, and you were given this kind of clearance graph, and it was labeled A, B, C, D, and then you were asked what were the different related to you. So you can see that this horizontal line indicates inulin, increase in the clearance. Increase in the clearance is glucose, and a decrease in the clearance a decrease in the clearance is with PAH, that is para-aminohippuric acid. Now, inulin has got this straight line which is just equal to that of GFR, that is 125 ml per minute. The reason is that inulin is neither secreted nor it is reabsorbed, it is only filtered. इसीलिए you will have GFR as GFR, the inulin clearance, which will be exactly same as GFR. Slightly more that of the creatinine, because creatinine ka clearance is 140 ml per minute. The reason is that creatine is a substance that is secreted. Now, as you keep on increasing the concentration of glucose or any substance which is reabsorbed and it requires a carrier protein. So any substance which is reabsorbed and it requires a carrier protein, and if you increase the concentration of that substance, what will happen? There will be a decrease in the reabsorption, है ना, because there will be saturation of the carrier proteins and therefore the clearance of that substance will increase. Okay, so any substance which is reabsorbed, उसका clearance क्या हो जाएगा? बढ़ जाएगा. क्यों बढ़ जाएगा? Because carrier proteins have become less. उसका clearance कितना भी बढ़ जाए, it will never go and touch that of inulin. It will be equal to inulin, or it will, you know, see, you can see. This is inulin. It is going parallel to inulin. It will never touch inulin. The reason is that inulin is not reabsorbed, and whatever may be the glucose concentration, small amount of glucose will always be reabsorbed. Next important is of the substances which are secreted, for example PAH, and these secretory substances are also requiring a carrier protein. So what will happen? Once they require a carrier protein for their secretion, and you keep on increasing the plasma concentration of that substance, what will happen? There will be saturation of the carrier protein, right? There will be saturation of the carrier protein and the clearance of that substance will decrease. Totally opposite to that of glucose. Totally opposite to that of glucose. Again, the clearance will be parallel to inulin but never equal to inulin, because inulin is not secreted. Right? So if there is a decrease in clearance, it is substance which is secreted. If there is an increase in the clearance, it is the substance which is reabsorbed. As simple as such. Next one. Now if you look over this, number of times the question has come on the cystometrogram, which is a relationship in the volume and the pressure of the urinary bladder. Okay, it is the relationship between the volume and the pressure of the bladder. So you can see that on x-axis is taken is the intravesical volume, and on the y-axis taken is the intravesical pressure. We can see that when there is an increase in small amount of volume, say around 50 ml, okay, so when there is an increase in the small amount of volume around 50 ml, there is an increase in the pressure which is depicted by this segment 1A. इसका मतलब initially, as there is a small amount of increase in the volume of the bladder, there will be increase in the pressure, right? But after that, even if the volume is increased, you can see that the volume is increased up till 400, you are getting this plateau, which is nothing but represented by segment 1B, which is nothing but the Laplace law over here. So accumulation of a small volume of urine around 50 ml will first bring about an abrupt rise in the pressure. इसके बाद if you keep on increasing the volume, the pressure will not increase, because the detrusor muscle, is the smooth muscle, okay, The detrusor muscle of the bladder is the smooth muscle which shows a very distinct property that is called as the plasticity, right? That means it will accommodate without increase in pressure according to Laplace law, which is T is equal to P into R. That means if there is an increase in the radius, the tension will increase. Okay, the tension will increase with the distending pressure, but the pressure will not rise. So with increase in the radius, there's going to be increase in the tension without increase in the distending pressure, and that allows accommodation, which is an example of receptive relaxation. Okay, it is an example of receptive relaxation, which is also seen in the stomach when there is food accumulation. Now, the unique property of the smooth muscles, that is plasticity, is that they can develop tension. Okay, they can develop tension at any length of sarcomere. They can develop tension at any length of sarcomere, and that too I am speaking about is the active tension. So they do not require any fundamental optimum length. So if there is less tension, they can if there is less length, then also they can develop tension. If there is more length, then also they can develop tension. See, initially you can see that the pressure rose 1A, but then the pressure stabilized. But again, when the volume is 400 ml, which is the point where there will be onset of the maturation reflex. This is the point when there is going to be an abrupt rise in the pressure that is going to result in the maturation reflex. So remember, the first sensation of emptying the bladder is around 100 ml. So when there is 100 ml accumulation of urine, there is a sensation of emptying the bladder, and at 400 ml there will be maturation reflex. The plateau phase is nothing, which is the Laplace law depicting the muscle property of the smooth muscles, that is plasticity. Now, next very repeated question which comes is on clearance, and especially on this formula. Now, what is clearance? It is volume of plasma. It is volume of plasma that is getting cleared. Okay, that is getting cleared of a particular substance. Okay, that is getting cleared of a particular substance as it passes through the urine per unit time. Per unit time, right? This clearance is given as U, that is urinary concentration of substance, divided by P, that is plasma concentration of a substance, into V, that is urine flow rate. Very importantly, concentrate over the units. So this can come to you as calculation based. This can come to you as calculation based. You may be given calculations. This can come to you as just asking you the formula, the units. So remember, the unit of U and P should be same. So it is milligrams per ml. It could be milli equivalents per ml. It is never per second or per minute, right? So always the unit of this urinary and the plasma concentration should be same. Urine flow rate is in ml per minute, and the denominator is urinary concentration. The numerator is urinary concentration and the denominator is plasma concentration. So two important things to be remembered with this question. Now moving on, next is very much important ion which is taken, and where the questions they come upon is the potassium ions. If you remember, this question was a part of INICT. The question says that 35-year-old patient with intravascular hemolysis, serum potassium has risen to 5.5. what will happen to its RMP? More positive, more negative, zero, or unchanged? Anybody would come up with the answer? Anybody would like to try? What will happen to the RMP? Yes. What is the RMP is? Now, what will happen to the RMP? See, this is the potassium, which we know is more inside. Okay, we know that potassium is more inside, and we also know that we have got leaky channels. Okay, so we have got leaky channels like this. Now, the potassium can go outside or come inside through these leaky channels. That totally depends upon the concentration gradient. Now, in situation when there is hyperkalemia, okay, in situations when there is hyperkalemia, what is hyperkalemia? When there is a rise in the ECF potassium. When there is a rise in the ECF potassium. So if already the potassium in the ECF is more, this potassium which is inside will not go outside, and the potassium concentration inside will increase, and therefore the RMP will become positive, and this tissue will become more excitable. So this is the question which was related and which was asked, that what will happen with hyperkalemia. So with hyperkalemia, the potassium which is already inside will not move outside, because now the concentration gradient is more in the ECF. So inside calcium need not go outside. So the RMP will become more positive. Similarly, if it is hypokalemia, then the RMP will be more negative. The inside will become hyperpolarized, because in that case the more potassium has to go outside to balance. Then this is the very important table which will tell you about the factors which take the potassium inside and outside. So factors that shift the potassium into the cells, that is decrease the potassium extracellularly, are insulin. We've seen that insulin stimulates, aldosterone stimulates, beta adrenergic stimulation stimulates the sodium potassium pump, and also alkalosis, right? Whereas the factors which are going to cause hyperkalemia, insulin deficiency, aldosterone deficiency, beta blockers, acidosis, and excess cell breakdown like with exercise can cause hyperkalemia. So this table is again very important. Then you were given one interesting question, that if the dorsal column is hit from the lateral side, which of the following fibers would be affected first? Now for this you must understand that what is the arrangement of the dorsal column fibers. The dorsal column fibers means I am speaking of the tractus or the fasciculus gracilis and cuneatus. Now fasciculus gracilis walk gracefully, is carrying the impulses from the lower limb. Eat, how we eat? From the mouth, upper limb. Gracilis is going to take its origin right from the lower portion, like from the sacral and lumbar fibers. Vertebrate is going to take its origin. So up till the mid-thoracic region, the gracilis is occupying whole of the posterior column. But when there is appearance of the cuneatus in the upper thoracic and the cervical region, in the upper thoracic and in the cervical region, this cuneatus will push the fibers of the gracilis more medially. So if you look over here, you will see that more medially are the sacral fibers, then the lumbar fibers, then the thoracic fibers, and finally the cervical fibers. So when there is appearance of the fasciculus cuneatus from the upper thoracic region, it pushes the fibers of the gracilis more medially, right? So from medial to lateral you have got sacral, lumbar, thoracic and cervical, and that is the reason that when there is a lateral hit, cervical fibers are affected, right? So you have to know the crossing of the fibers, you have to know their arrangement in the spinal cord, because they are maintaining a very precise spatial fiber organization even in the thalamus, right? So this becomes an entire different topic to be considered, boys and girls. So whatever possible we could complete today in a session of 1 hour. I hope the session was enjoyable, was interesting, and was learnable. Now one thing which I should tell is, we always think of studies and studies and studies, but I think the first thing which we should think about is what thoughts are we creating in our minds, because these thoughts actually become our destiny. Yes, if you are always thinking negative, you are getting and sending the negativity to the universe and getting it same. But if you are generating positive thoughts, okay, if you are generating positive thoughts, you get that positive energy reflected. Once you energize yourself with positivity, your mind, and believe me, the universe shows you ways to reach towards your goal. So the first thing which we must remember before we are doing anything in life is living a life living a life with gratitude. First, being thankful to whatever we have, and second important thing, always generate positive thoughts in the mind so that our life is positive and beautiful. So thank you everyone. We'll come up with another session. I think this session is going to be for FMG very soon. My next class is possibly on 19th June, where I'm going to take last 5 years. I have tried, last 5 years MCQs for FMG. So even if you are preparing for NEET PG, for INICT, the MCQs are MCQs, isn't it? So you can join the session, and please don't forget to put a comment if you've liked the session. Thank you very much. Happy learning, and God bless you all.